Hey everyone, this is Dr. Medicine RX and in today's video we'll be discussing about pellagra. Pellagra is a nutritional disorder that occurs due to deficiency of vitamin B3 or niacin, which is a water-soluble B-complex protein. This niacin it is obtained one directly from foods and two it can be synthesized in the body from tryptophan. Coming to sources, food sources of niacin, these include legumes, groundnut, fish, poultry and meat. Coming to function, niacin forms two important coenzymes, nicotinamide adenine dinucleotide and nicotinamide adenine dinucleotide phosphate, which are required in cell metabolism and fatty acid synthesis. And along with that, nicotinamide also enhances epidermal permeability barrier. Coming to epidemiology, it is common in rural areas where the staple diet are corn, maize and jowar, and also where there is decreased intake of animal protein, fruits and vegetables. So corn and maize, they contain niacin in tightly bound form, which should be released by alkaline hydrolysis for absorption. And jowar has high levels of leucine, which inhibits the conversion of tryptophan to niacin. Coming to age, it is commonly seen in middle-aged individuals and it is almost never seen in infants and young children. Gender, there is equal distribution in both males and females, and it is commonly seen in the winter season. Coming to etiology, it can be because of decreased intake, decreased absorption or because of impaired conversion. Decreased intake can be due to because of poverty or in individuals with eating disorders or alcoholism or those that have food allergies. Decreased absorption because of inflammatory bowel disease, gastric bypass surgery, gastroenterostomy, jejunolitis, heart nerve disease, etc. And impaired conversion because of certain drugs or because of carcinoid syndrome, where in carcinoid syndrome tryptophan is converted to serotonin instead of niacin, and certain drugs such as isoniazid, 5-fluorouracil, 6-mercaptopurine, which predominantly inhibit the conversion of tryptophan to niacin. Also, there are other drugs that may play a role such as anticonvulsants, antidepressants, azathioprine and chloramphenicol. In addition to niacin deficiency, impaired zinc and fatty acid metabolism can also cause pellagra. Coming to pathogenesis, as there is decreased NAD and NADP, there is decreased energy supply for transfer reactions. As a result of this, tissues that have high energy requirements such as brain and tissues that have high turnover rate such as skin and gut are predominantly affected. This leads to the three classic features of pellagra. And along with that, the reason for photosensitivity and cutaneous lesions in pellagra is because of decreased collagen in dermis along with decrease in skin urocanic acid and altered porphyrin metabolism. So the three classic clinical features of pellagra are dermatitis, diarrhea and dementia. The earliest features of this deficiency in the beginning are anorexia, irritability, weakness and fatigue. This is followed by the cutaneous features, which are precipitated by exposure to sunlight, fire or radiant heat. Dermatitis, it is acute and intermittent, it is painful and pruritic and it is seen in the photodistributed areas. So the lesions, they begin as well demarcated areas of erythema with pruritus and burning, and this erythema in the beginning stages resembles sunburn, and it appears symmetrically over the sun exposed areas. These sun-exposed areas include dorsum of hands, where it is called as gauntlet of pellagra, or the forearms, the face, V area of the upper chest, elbows, knee and dorsum of feet. And sharply demarcated lesions in upper central portion of chest and neck is what we call Castle's necklace. Now, in the areas of friction, these lesions, they can be thickened, they can be inelastic and deeply pigmented. And on the face, they appear as dull red erythema on bridge of nose, cheeks with powdery scaling, and eventually it forms this butterfly erythema and gets pigmented. And in intertriginous areas also, even though they are not sun exposed, there can be erythema and maceration, and in severe cases, vesicles and bullae form as a result of photosensitivity. In chronic cases, the patches, they turn reddish brown, they become more scaly and thickened and pigmented. Later, they become atrophic and they desquamate. Coming to mucosal lesions, oral mucosa is commonly affected in the form of cheilitis, angular stomatitis and oral sores. So oral mucosa along with the tongue, they appear very inflamed and swollen and ulcerated, and they have this bright scarlet color which is called as scarlet glossitis and stomatitis. This tongue also has enlarged fungiform papillae with atrophied filiform papillae. Coming to vaginal mucosa, there can be vaginitis and vulvitis, and in males there can be scrotal dermatitis. There can be involvement of urethral mucosa and perirectal mucosa, where in perirectal areas it can present as sores. Coming to GI manifestations, so abdominal pain, nausea, vomiting and diarrhea, and neurological manifestations include headache, anxiety, insomnia, apathy, depression, psychosis and dementia. Coming to other clinical features, bilateral parotid swelling, which leads to increased salivation. This bilateral parotid swelling is because of this malnutrition causing protein deficiency. Then there can also be encephalopathic syndrome, wherein there can be clouding of consciousness, cogwheel rigidity, and uncontrollable sucking and grasping reflexes. And there can be exaggerated deep tendon reflexes. Myelitis, decreased nerve conduction, incoordination, peripheral neuritis, and tremors can also occur. Coming to differential diagnosis, one is polymorphous light eruption, cutaneous LE, chronic actinic dermatitis, and then porphyrins or porphyrias, and pyridoxine deficiency and photosensitive eruptions. Coming to investigations, it is predominantly a clinical diagnosis. Complete blood picture, it shows megaloblastic anemia, and urine examination shows decreased urinary niacin metabolites. On histopathological examination, the findings may differ depending upon the stage of the lesions, but there can be hyperkeratosis, patchy parakeratosis, acanthosis, and increased melanin throughout the layers of epidermis, elongation of retina ridges, sebaceous gland and hair follicle atrophy. And along with that, there can also be peripheral cutaneous nerve degeneration. Coming to management, the required dietary allowance of niacin is 10 to 20 mg per day, but in cases of deficiency we have to supplement in doses more than that. So first we can go for topical measures such as zinc oxide and sunscreens, because there is photosensitivity and also erythema of the lesions. And then for oral supplementation, niacinamide it is preferred instead of nicotinic acid, because it can cause headache and flushing. So niacinamide in a dosage of 300 to 500 mg per day in divided doses is given orally, or if at all there is no in cases where there is decreased absorption or we can't give orally, we can go for IM, intramuscular formulation, in the form of 100 mg for 3 times a day. This 100 mg should be given at each time for 3 times a day. So it is not divided for 3 times, it is given at every time for 3 times a day. And along with that, in severe cases where there is encephalopathy, we also give oral 1000 mg of niacinamide per day. Along with that, we also give parenteral formulation of 100 to 200 mg. Along with niacin, we also have to supplement pyridoxine and riboflavin for neurological manifestations, and also supplement protein and iron. We have to suggest the balanced diet and adequate intake of niacin and tryptophan rich foods, and to avoid maize and jowar. Now these skin lesions following treatment, they disappear in few weeks, whereas neuropsychiatric symptoms, they improve in 24 to 48 hours. Thank you. Subscribe for more.